So we'll move on now to types of surveillance. We'll talk about active and passive, risk-based, sentinel surveillance, targeted surveillance, syndromic, participatory, and indicator versus event-based, and we'll again point out what a survey is. I think we talked about a survey yesterday as well. So this is all about how to find cases. And I think we should think about this sort of as the sampling part of surveillance. So we'll talk about active versus passive first. So active surveillance is when the investigator actively seeks out and finds cases. So you as the investigator will decide which animals are sampled, and you will control that. And this is often by sampling the target population. For example, an example is a random sample of cattle in Switzerland to estimate the prevalence of BVD. So below is the risks definition, which pretty much says the same thing as my notes on the top. So decisions about whether information is collected, what information should be collected, and from which animals is made by the investigator. So the pros are that it is representative of the population. At least it can be if it's done properly. It can produce valid estimates of population parameters, and by valid we mean that the estimates from the sample are the same as those in the population. However, it's expensive and it's labor and resource intensive. It's not continuous because we're going out and collecting a sample, so it's not good for early detection. And if you don't know the sampling frame, you really can't do it properly. And although in Europe, most countries know where all the farms are and have an ID for all the cattle, and for most pigs, most countries in the world still don't have that. Even the US does not have that. So it's impossible really to do a national survey that you can defend as being valid without having that sampling frame. Passive surveillance is when the investigator doesn't actively seek cases. We just wait passively for the cases to appear. So cases are reported. The first and the most common and the most easy passive surveillance programs are reportable disease programs. So the investigator doesn't, we do things, but we don't define which cases are reported. The people that own the animals decide whether they're going to report a case or not. And often this is data that's collected for other purposes. So for example, using meat inspection data for surveillance or using veterinary practice data for surveillance would be examples of passive surveillance. And we still, even though there are problems with passive surveillance, we still do a lot of passive surveillance in animal health and in public health. So in this case, decisions about whether information is provided and what information is provided from which animals is made by the data provider, because a data provider also can decide whether they give you some information or part of the information or all of the information. The pros is that it's continuous, so it's good for early detection. It's inexpensive, but because we have little control over who submits the data, it's never representative of the population. From veterinarians, some animals are not seen by veterinarians, so often it's a challenge with sheep because individual sheep may not be of high enough economic value for farmers to call their veterinarians. So you may see few sheep visit if you're doing veterinary practice surveillance and even diagnostic laboratory surveillance. You may see little data about sheep. So it's dependent, of course, on the willingness of people to report cases. So people have to be aware of the importance of reporting the cases, and stigmas have to be removed from reporting the cases. So the first case of BSE that was reported in Canada was not really even reported. It was a farmer who shipped an animal, an older cow who was down, and the cow was just ended up being in our surveillance program for BSE, and it turned up positive, and that farmer was stigmatized by his neighbors to the point where he sold his land and quit farming in that area and moved somewhere else to start farming again. So stigmatizing the cases, or stigmatizing reporting, is a strong detriment to people reporting cases. So we talk about enhanced passive surveillance, where we do things to try to encourage people to report cases. So there can be monetary or other rewards. Training and awareness campaigns are very, very important to show people that it's important to report cases. Indemnity programs for stamping out. So if your reporting is associated with the farm being quarantined and the animals potentially being euthanized, then having good indemnity programs is essential, because if farmers think they won't get paid for the animals, they're not going to report them. So we have one question. So which are passive surveillance activities? So this, I'm interested to see what people think. Everybody has a hard time. I have a hard time with this. So which are passive surveillance activities? Remember, passive activities are activities where the investigator does not decide whether the animals are submitted or not. Those decisions are made by the animal owner. Active surveillance is when you go out and you do a survey. You randomly select animals from the population, and you decide which animals you select and which information you're going to collect from them. Passive surveillance, weekly reports of VVD cases at a diagnostic pathology laboratory would for sure be passive, because you have no control over who submits cases to the cases or samples to the laboratory for testing. A national sero survey to estimate the prevalence of brucellosis would be active, because you're randomly selecting animals from the population and testing them. Mandatory reporting of AMU on farms by farmers is also passive. Even though it's mandatory, it's still considered passive, because people can decide not to report, even if it's a mandatory program. Random samples of meat from grocery stores to detect E. coli. I thought this might trip people up a little bit, because it's random samples. So here, it would depend on what you thought was your target population. If the target population is cattle in the country, then it would be passive surveillance, because people submit their cattle to slaughter by their own choice. So you have no choice of which animals end up there. If it was the retail meat, you might think that it was active, because you're taking a random sample of meat in meat counters at grocery stores. But then again, you have no real control of which meat the butcher puts out in the meat cases at which time. So I don't know. I think I agree. I would have called that passive as well. Daily reports of COVID cases. People put so much emphasis on this right now, and it's still passive surveillance, and it suffers from all the problems that we have with passive surveillance. Continuing along, we'll talk briefly about risk-based surveillance here, and we'll talk a lot more about it after lunch. Risk-based sampling is part of risk-based surveillance, and we use risk factors to identify subpopulation where we're most likely to find the disease. And this risk factors can be many different types. So it can be a geographic region, can be time, so season. We won't look for blue tongue virus in midges in the winter because we won't find them. Age, we looked at well, Schmallenberg virus would be fetuses and newborns. Production type would be important. And the idea is that you sample then in high-risk subpopulations. So trichinella, for instance, we would focus on farms with outdoor pig rearing because that's a very strong risk factor for having trichinella in pigs. Pros are it's economical and resource efficient, and you can get the information you need using less resources usually. But again, it's not a random sample, so you have issues of validity, and you have to be very cautious about generalizing to the whole population. You can, but you have to be very careful about how you do it, and you have to be very certain about what you're doing, because you're taking a sample from only a subset of the population, and you're making inferences about the whole population. Targeted surveillance is an old term that was around for a long time before risk-based surveillance and risk-based sampling was around. Now it's considered part of risk-based sampling and surveillance. You'll see this term used in lots of places. It generally has two meanings. One, it focuses on a specific hazard, so we target foot and mouth disease for surveillance. The other is it focuses on a specific subpopulation, so this would be the same as risk-based sampling, where we target some subpopulation where we think we're most likely to find the hazard or the most likely able to measure or best able to measure the risk from the hazard, and we focus our surveillance resources and our sampling resources on that subpopulation. Sentinel surveillance is similar. It's also often considered part of risk-based surveillance. And it's an older term as well. It's been around for a lot longer than risk-based surveillance has. It's where we define a subset of the population and we sample it a lot. So we do sentinel surveillance of cattle farms or pig farms, and here we select certain farms throughout the region we want to do surveillance on, and these are usually farms that are compliant, that is farmers that are willing to work with the program, and then we sample them over and over and over, either looking for the prevalence of the pathogen or looking for information and questionnaires from the farmers. So that would be sentinel farms. We also do sentinel veterinary practices and sentinel animals. We talked about, you'll hear the term indicator-based surveillance and event-based surveillance, and this is here just to differentiate between the two terms to avoid confusion. So indicator-based surveillance is traditional disease surveillance, where we find and count cases, and we analyze data to determine if there are indicators of a disease epidemic, or if the disease is going up, or maybe even if the disease is going down. So the indicator-based surveillance is traditional finding and case counting surveillance. Event-based surveillance, also called media-based surveillance and digital surveillance, is surveillance of events, not individual cases. So events can be outbreaks, epidemics, or events that can be in some way indicative of an increased health risk. So ProMed is event-based surveillance because people report outbreaks and epidemics that they see in newspapers. Oh, I got a typo there. Health Map is another one. GFIN is another one. And often countries have their own event-based surveillance where they do event scanning or horizon scanning, looking for events in other countries that might indicate that there's an increased risk of disease in their own country. And so they're often based on rapid risk assessments. So you find out about this information, and then you have to assess it in terms of the likelihood of entry and the consequences if it does enter your country. Syndromic surveillance, we don't really talk about a lot in this course. It is when we do surveillance where the cases are unconfirmed surrogates for the hazard. And so they are pre-diagnostic. They're done, we look at surrogates or things that happen in the population, often, well, most often, human behaviors that occur before a diagnosis is made. So we look at abortions, not looking at the causes of the abortion, just count the abortions that occur, somatic cell counts, mortalities in cows, something like adult cows seen with diarrhea by veterinarians. It's much more common in public health, where they do surveillance of sales of diarrhea medications in pharmacies, and they monitor people who are absent from work and things like that. It can be focused on a particular hazard, but most often it's not hazard specific. It looks for any change in the population. And the idea behind this is that if there's a disease in the population, whether it's humans or animals, the animal owners will respond in some way and change their behavior. Go to the local feed store and order medicated feed, or purchase anti-diarrhea medications, or purchase electrolytes for their calves. And those behaviors are monitored. And if there's an increase in those behaviors, they might be an indication that there's an epidemic in the population. So this is based on this. I stole this from Fernando Dorea, on this idea where on the top three bars are the size of the human population, companion animal population, and livestock populations. And the top bar shows the number or the proportion of the population that are exposed. The next three bars below are the health providers, the proportion of the population that gets that seeks help or goes to a health provider. The next one are the proportion of the population that sends samples in for laboratory submission. These are usually from veterinarians. Then it's laboratory confirmation and notification. And time in days goes from the top to the bottom. And the idea behind syndromic surveillance is to identify changes in the disease status of the population earlier in this chain of events. And there's many studies in public health that shows that syndromic surveillance can beat traditional surveillance in timeliness, often by days to even 2 weeks. Participatory surveillance is surveillance involving stakeholders directly in surveillance activities. And this can be any place along the surveillance continuum, from designing the surveillance system, identifying the important hazards, conducting case finding and case counting, communicating the results, and then they can also be involved in the responses, designing the responses and implementing the responses. So it's much more common in some of the developing countries, where compliance, even with legislation, would not be good. So involving people and different stakeholders in the surveillance process itself improves compliance. Just quickly, a survey. A survey is not surveillance, and it's not a study design. It's simply a tool that is used to measure specific attributes. We use surveys in surveillance all the time, but they themselves are not surveillance. I mean, they're not even monitoring. They're part of monitoring, they're part of surveillance, but they aren't surveillance. So example would be a questionnaire to survey farmers' attitudes, or a sero survey to estimate the prevalence of disease. Both of these would be surveys, and they would provide information that's part of surveillance, but in themselves, they are not surveillance. Okay, are there any questions? We talked about the different types of surveillance. So before this, we talked about the information that we created with surveillance. These are the different types of surveillance: active versus passive, risk-based, sentinel, targeted, syndromic, participatory, indicator versus event-based, and we talked about surveys. So just now is sort of a hodgepodge or a collection of different things that we should think of when we're designing surveillance. So resources we just mentioned briefly, hazard characteristics, the purpose of surveillance, we've already talked about it, epidemiology of the pathogen, some of the characteristics of surveillance, and something about surveillance components. So hazard characteristics, what you have to think of when you choose which type of surveillance you use is, obviously, is it present or absent? Is it known or unknown? So we do surveillance for unknown diseases, so emerging previously unseen diseases. Is the prevalence high or is it low? Those will all affect both for active and passive surveillance. For active, it'll affect how big your sample size is when you're doing your sampling. For passive, it will influence how specific you can be with your case definition. Long or short incubation period is important. You have to design your surveillance to check. I mean, if it's a long incubation period, like Johne's disease, where you rarely see it in animals under 2 years of age, you'd have to do surveillance of animals older than that. Whether transmission is rapid or slow. Again, Johne's is a good example where it's maternally transmitted and there's little transmission between adults, so you design your surveillance system around that. And also whether it's clinically distinct or similar to other diseases. If it's clinically distinct, that gives you a distinct advantage because then farmers will be able to recognize it, veterinarians will be able to recognize it, as will pathologists. So I would again send you to the RiskSur project. They developed a really good tool for designing surveillance systems, and it takes you through step by step by step. So if you ever have to design and implement a surveillance system, it's a good website to look at, and this tool is very good because it's very comprehensive and it doesn't really miss out on anything. So it's good to go through and use it just as a checklist to make sure you've done everything and make sure you've considered everything. Of course, we always have to remember this about the basic principles of epidemiology, and surveillance is based on those principles, which is why this was an introductory course to epidemiology and surveillance, just to bring forward some of those more important parts of surveillance of epidemiology that are important for surveillance. So in all stages, data collection, data analysis, interpretation, action, and assessment, having a good, strong basis in epidemiology is important. We can talk about surveillance sensitivity. We've talked around this a little bit, but not really directly. So when you increase the surveillance sensitivity, so the sensitivity of either a surveillance activity or your surveillance system, you increase the probability of finding cases. And you can do that in a number of ways. You can increase the coverage, so make sure that you're sampling in all regions of the country, increase the sample size, reduce the design prevalence. You can broaden the case definition. You can do things like risk-based surveillance, so target more resources in that strata where you're most likely to find the disease. So if it's only a disease of females, only do surveillance of females. Provide for passive systems, provide incentives for reporting, and make reporting easy for people so that it's not difficult. Don't make them have to fill out a great big form online to report the case. Consider the consequences of reporting, so make sure that there is no stigma against reporting and that you pay good indemnity if you have to quarantine and remove the animals. Of course, as Maria talked about yesterday, use a sensitive test, and then having a well-trained veterinary service, well-trained surveillance practitioners, good technique and quality insurance are all important so that you don't make mistakes anywhere along the line from when you collect the sample to when you analyze it and report the results. Surveillance specificity is also important. So we all know from yesterday that if you increase the sensitivity, yes, you'll increase the probability of finding cases, but you will likely also increase the number of false positives. So you have to also always think about that. So use a highly specific case definition, highly specific test. And of course, again, we need to balance these with sensitivity. You can use serial testing and proper training, technique, and quality assurance. So, and the other thing that we often do is do a full investigation of all test positives in your first round of surveillance to ensure that the test positives are true positives, or at least that you separate the true positives from the false positives. Timeliness is important, how long it takes to detect and communicate the disease from the time when it enters the population till when you communicate the results that there is not just a case but an epidemic. This is critically important for early detection, and often we make at least one component of an early detection system continuous. Or you can use frequently repeated surveys, but they're very costly, and both in terms of financial resources that are needed and human resources. Having a good case definition that focuses on the early stages of the disease is important. You can increase sampling if you're doing repeated studies, or increase the frequency of observation. And rapid sample collection, rapid transport, and rapid confirmation of test results, followed by rapid notification, are all important. So we consider the time between when something happens in the population, we collect the sample, we test it, we confirm it, and then we get the results to the people that need to make the decisions as the timeliness. Population coverage is important for early detection and for case finding. And here we mean that is your surveillance penetrating all parts of the population? If it's not, you can target additional susceptible hosts, ensure all parts of the population report. You can make sure that all costs for cases are borne by the investigator, so there's no additional costs to the people that report it. Public awareness campaigns are important. Incentive for reporting and indemnity I've already talked about. And sampling point may affect coverage. So we'll talk a little bit about some of the common sampling points a little bit later. Population representativeness is a little bit different than the population coverage. So representativeness means that your results accurately reflect the characteristics of the population. So this is about validity. If your surveillance says the prevalence is 10%, if that's valid, then the true prevalence in the population will be 10%. And to have representativeness, you think about the sample, you think about things that for passive programs, things that may affect whether people report or not, public awareness campaigns, increasing the coverage, and always assess the representativeness of your samples. So look at the descriptive statistics, sex, age, production type, location, and compare them to census figures to see whether your sample is actually representative of the population. Bias is important, and there are many things that can cause bias. We haven't really talked about many of them, but poor case definitions can bias your sample, as can imperfect diagnostic tests and sampling errors. So if you collect your sample in the wrong place, and if it's not random, you can bias your results. And also sample handling. So if samples are improperly handled and the staff doing the testing and collecting are improperly trained, that can lead to an increase in especially false negatives, but sometimes also false positives. Precision, I'm not really going to talk about. We talked about it before. And it relates to sampling, whether you use non-probability sampling or probability sampling. And this, of course, depends on what type of surveillance and what type of information you're trying to get about which one you use. And always be careful about non-probability sampling, because it's difficult to make generalizations about the prevalence to the population using non-probability sampling. And resources are always important. There's this constant increased demand for animal health and food safety information. And I think with the advent or the popularization of big data, we're expected as surveillance practitioners to produce more and more information about animal health, food safety, and animal welfare. So there's this constant demand for more information, and I don't see that we're getting more resources for veterinary services. Sometimes we are, and usually when there's a serious disease epidemic or outbreak, we often, sorry, I need to get my time back here. We often get a flush of resources that lasts for a little while, but then they're often reduced and reduced and reduced. So solutions are to prioritize hazards. Only pick those hazards that are important. Use risk-based surveillance to get more information for the same amount of resources, and consider multi-hazard surveillance. So multi-hazard surveillance is when we do surveillance for many or multiple hazards at the same time. So it can be a parallel design where we do surveillance for multiple things. The example here is a survey to prove freedom from PRRS and porcine circovirus at the same time. And also we can use secondary use of samples. So surveillance designed for one hazard, we collect data and samples and we use those for other purposes. So one is the mother component, the other are the child component. An example is veterinary practice record surveillance. We can collect data from veterinary practices about many, many, many diseases at the same time. And this is secondary data because it's being collected by veterinarians to manage their cases, but we use it for surveillance as a secondary use to see if we can determine whether there's changes in the health status of the population. So we haven't really talked about multi-component surveillance, but most surveillance is done as systems where we might look for a specific hazard, but we use many, many, many different components for that surveillance system. So the example that some people talked about was tuberculosis surveillance. We look for lesions in the slaughter plant. We also might do a random sample of adult animals in the population, or we might target certain areas where there's exposure, say, to animals that might be reservoirs. A surveillance component, so surveillance systems are made up of many components, and a surveillance component is one single surveillance activity of the many that you use in your surveillance system. So if we examine cattle for TB-like lesions at slaughter, that would be one surveillance component. So this is an example of that I use from the United States to talk about a surveillance system in US states. So each US state has to prove that they're free from tuberculosis. And they have to estimate that there's less than 0.0006% of the population infected. And so each state must do this with surveillance and present the results to the USDA for accreditation. But infected herds still occur sporadically. So there are cases of tuberculosis. And each state actually goes to a lot of trouble to try to maintain their bovine tuberculosis free status, because otherwise they can't move cattle across state borders. So each state has a surveillance system, and they must, number one, make TB reportable by law. So that's a passive surveillance system, and then conduct surveillance to demonstrate the prevalence of TB is less than 2%, with 95% confidence in cattle and bison populations. So they select farms And then they use a cattle fold test on the farms to test a specific number of cattle. So they do a sample of cattle populations and bison populations. So that's an active surveillance system. They also do slaughter surveillance. And this is the majority of their surveillance, and this is done from animals that usually are older, I think older than 2 years of age. And I haven't been able to find any updated figures, but I suspect it still would be about 6 or 7 million cattle that are slaughter tested for TB every year. And they also have a veterinary infrastructure that can conduct, that's trained and can conduct a TB eradication program. So we have a few minutes left. We have one exercise left to do in this, but I think we'll do it after lunch. So I'll go through these last slides. I wanted to talk a little bit about convenience sampling because we still do a lot of convenience sampling in animal health surveillance. So, and I want to talk specifically about places where animals are collected. So with convenience sampling, the pros are it's easy to access large numbers of animals. You can get reasonably good coverage of the population sometimes, and you can use this sort of surveillance to identify trends in disease in the population, but you have to determine whether the change in what you see is due to change in disease in the population or change in the way people are submitting animals. So even if you see a changing trend, it usually has to be followed by some sort of active surveillance. And of course, the problem with this is that it's biased in many ways. Only healthy animals are presented to slaughter, for instance. Sick, dead animals often don't make it into surveillance systems, especially if they're not animals that are worth a lot of money. So valid population estimates are often not possible. So we'll talk first about farmer reporting. It's good for early detection. We can use farmer reporting, especially mandatory programs. We can often justify using that for disease freedom. They are good for identifying important diseases because farmers are the closest to the animals. We can also detect changes over time, and it's good for finding cases. But of course, it's only good for diseases that are unique and easily recognizable. It's not good for diseases that don't show clinical signs. You can't accurately measure the amount of disease, and it can't be used for diseases that are stigmatized. Veterinary practice surveillance is similar to farmer reporting. It's more specific, so veterinarians are better at differentiating the causes of disease. It's less likely to be affected by stigmatized diseases. Again, the livestock must be of value to support the veterinarian coming to see the disease, and it must be serious enough that the farmer also wants to call the vet. And I think the last one is veterinary diagnostic laboratory surveillance. It's good for previously unknown or unseen diseases, and it's often the place where we identify new, previously unseen diseases, so it's very important. It is used when high specificity is required, and we can use it for identifying trends. We have to be careful about whether the trends we see are due to changing trends in submissions. Often you see these due to government programs where they provide monetary incentives for farmers to submit certain animals. So you have to differentiate between whether it's that or whether it's due to an increase in disease. So you can't do valid population estimates. And it's not really good for early detection because there's some time between when the disease occurs on the farm, it gets serious enough, the farmer calls the veterinarian comes and has a look at it and then submits a sample. So sometimes not really early. There's differences between veterinary diagnostic labs in terms of their diagnostic approaches, the tests that they use, the level of investigation into animals submitted for postmortem, etc. and the language itself is not standardized. So this makes it a problem for using this data in different countries.